everybody. And my name is Pradeep Krishnan from the Hospital for Sick Children, and I'll be talking on pediatric stroke neuroimaging. Before I begin, I would like to thank the organizers, including Dr. Swaminathan and the team, for kindly inviting me to speak at this forum. And also want to acknowledge Manu and Astik, my former colleague at Great Ormond, helping with the slides. The objectives of today's talk are to look at etiologies in childhood arterial ischemic stroke, some of the neuroimaging approaches and patterns in pediatric stroke, and challenges including stroke mimics. I'm a diagnostic neuroradiologist, so basically I would try to highlight some of the differences when you're doing it from adult stroke perspective as well. Before we begin, just to look at the incidence, it's about 2 to 13 per 100,000, and about 50% of these are arterial ischemic strokes. The more important part is the morbidity associated with it. About 60 to 65% of these strokes can have neurological deficits. Mortality is in the range of 5%, which is still amongst the top 10 causes of death in pediatric patients. Neonatal strokes have a higher incidence. We won't be going into details, but one of the things for residents and fellows to remember is that about a half of these strokes are within the first year of life. So that's important to remember, and then it's sort of scattered evenly. Apart from neurological deficit, when you talk about morbidity, you are also going to look for cognitive dysfunctions and behavioral issues, as well as epilepsy. Now, what are the challenges in childhood arterial ischemic stroke? One is delay in diagnosis, and unlike adults, the diagnosis seems to be a huge challenge when you're looking at pediatric strokes, and the mean diagnosis is almost up to 24 hours. One of the other challenges is even when you do have a suspicion, there is a major bottleneck in terms of general anesthesia for these patients, and also the fact that you prefer MR compared to CT, unlike adults. You might not have the facility at a peripheral center for a 24/7 MR coverage. And the reason why you prefer MR is that there is a lot of stroke mimics in pediatric arterial ischemic stroke, and we'll talk about that as we go walk along the talk. And also the causes, the etiologies are much more diverse. Now, why do you need to aggressively image that? Is that 1 in 5 might have a recurrence, and more importantly, patients who have abnormal vascular imaging at baseline in a pediatric arterial ischemic stroke, 2/3 of this tend to have a risk of stroke in the next 5 years, and that's a major implication. And that's why you want to treat them aggressively, image them aggressively, and that's one of those major drivers to image these patients. Now, we talked about diverse risk factors, and unlike adults, you have a broad category of causes which can cause these pediatric ischemic strokes, including arteriopathies, congenital heart diseases, prothrombotic stress, systemic illnesses, infection, genetic, drugs, etc. And in a quarter of these cases, you might still not identify the exact cause. Now, if you look at stroke protocols, in a code stroke protocol, because MR is preferred, unlike what is the usual trend in an adult setup, you prefer to do an MR which is probably short within 10 minutes at our institute, and this is an institutional practice. What we do is diffusion, a gradient, an MR angiogram for the intracranial vessel, sometimes the extracranial if it's required, and an axial T2 or a flare, which is the goal being that you diagnose it fast and prepare it for the interventional team. If it's a subacute or a more chronic situation, then you would probably add perfusion, you would add vessel wall imaging, and there are many consensus protocols if you want to read this from the IPSS group. Now, the code stroke protocol in our hospital, I'm not going to read out the entire busy slide here, but basic drivers are that you want to recruit the neurology, the stroke service, ER, radiology, and intervention as the patient comes to the ER or before he comes to the ER. And so you can mobilize imaging studies. In fact, you might want to recruit dentistry also in cases of pediatric strokes. Many of them have dental braces, which might be a limitation. And when you do find a large vessel arterial stroke, and you want to do an endovascular procedure, the things are all lined up and the window period is shorter. Some of the things which I want to highlight before we move on to the topic for residents and fellows is that when you're looking at arterial ischemic strokes in pediatrics, some of the things which are slightly different from adults is that you might see an acute Valerian degeneration very soon, almost as along with the evolving stroke. Here is an MCA infarct. You can notice changes in the basal ganglia and the thalami simultaneously with the corpus callosum and extending along the corticospinal tracts within the brainstem. And this is presumed to happen because of the transsynaptic degeneration in an immature connection, the thalamocortical connections being stunned as you have a large cortical infarct, and that causes these kind of changes which are a bit earlier compared to what you are used in adult. The other important point to point out is that most of these arterial ischemic strokes, you probably do not see an abrupt vascular occlusion which are used to in adults. Here is a MCA stroke, the posterior division. Notice the robust left MCA on that side. Similarly, a PCA infarct, the left PCA is sort of better seen and a higher signal. And one of the causes attributed to this is the deranged cerebrovascular reactivity. The autonomic system is immature, and so there's a luxury perfusion which causes increased signal on the MRA, and that's what you usually see. So some of these changes of a deranged severe cerebrovascular reactivity is typically common in the second to third days of the event happening, unlike adults where you see an abrupt cutoff. When you come to the spectrum of abnormalities, and arteriopathy being the largest group, you will probably include focal cerebral arteriopathy, dissections, vasculitis, and moya. We are not going to talk on hemorrhagic stroke on this talk. So what is focal cerebral arteriopathy? Typically, it involves a unilateral carotid T bifurcation, as you see in this case, the terminal ICA, the proximal M1A1 origins. There is a mild asymmetry. There is narrowing in this patient with 11 years old evolving acute stroke, history of rash 4 months ago. There's typically some narrowing, but no occlusion, and the site is typical unilateral. You might have bleeding in some of these patients. In this particular patient, it was flagged as a focal cerebral arteriopathy. Further evaluation with vessel wall imaging, notice the concentric enhancement of the vessel wall at the carotid T bifurcation in the M1A1 location. For residents and fellow, that's the contralateral normal side. And this is important to remember that this might be a good site to assess vessel wall enhancement. And the reason why is that you don't have the perivenular plexus as prolific as you do in the distal segments, and so this might be a good area to judge for vessel wall enhancement if you're looking for, unlike the cavernous sinus and the distal MCA. Typically this would resolve in a few months, and many of these cases will restore a normal vessel caliber over a period of time. One of the important things for residents and fellows is again to remember that there is a relationship between infections and strokes in children. Infection acts as a trigger, and then there is a cascade of cytokine inflammation which causes probably the vessel wall injury and inflammation and causes stroke. And that has been seen in the WIPS trial. About 18% of these cases has some sort of infectious trigger preceding to the stroke in the few weeks or months. A classic example of a vascular insult because of a focal cerebral arteriopathy, chickenpox 3 months ago in a 7-year-old child, lenticular striate involvement, irregularity of the MCA, poor flow signal. A year later, notice the chronic sequelae. However, the vessel seems to have remodeled and restored its caliber, which will be typically in a focal cerebral arteriopathy. The beading of the vessel is another clue when you're looking for vessel wall focal cerebral arteriopathy, which might be better appreciated on a catheter angiogram. However, you might see it sometimes in an MR angiogram, and the restoration of the caliber over a period of follow-up. Another example of a brainstem infarct, notice multiple infarcts in the brainstem on the T2 coronal. The vessel wall seems to be normal in caliber. However, when you do a vessel wall imaging, notice that there is diffuse enhancement of the PCA as well as the right PCA on the contralateral side. It's circumferential. The distal basilar also shows enhancement. So one of the important things is, unlike adults where you have atherosclerosis, your major differential and most common cause, in pediatrics, not only the lumen, but the wall of the vessel is more important at times to evaluate. And these vessel wall sequences are important when you're evaluating these strokes. And this was a medium vessel vasculitis. Danny is probably speaking on vessel wall tomorrow, and he writes the guideline. He's an expert on this, and he will tell you some of those clues about how to image these and look at these. So that's the enhancing vessel wall on both sides, which we showed in this particular case. Now, why do we use the term focal cerebral arteriopathy instead of transient cerebral arteriopathy? And the reason why we do it is that a proportion of these cases can have a progressive phenomena. This is another example, classic location of the lenticular striate involvement and terminal ICA involvement. Notice the enhancement in an acute setting. The contralateral side doesn't enhance, but follow-up, notice that there is a chronic sequelae, but there are collaterals which are cropping up in this particular situation, and that is a progressive vasculopathy in spite of the fact that it is a arteriopathy. So that can happen in a proportion of these cases. Apart from focal cerebral arteriopathy, other considerations would include moya-moya, NF1 trisomy, sickle cell disease, and dissections. The inflammatory causes like vasculitis because of primary CNS or angiitis or Takayasu's, although are differentials, are not as common when you're talking about pediatric strokes. Coming on to moya-moya, basically, sometimes you might see these acute negative diffusion. T2 doesn't show any significant abnormalities, maybe sulci are slightly prominent, but the flare helps. Notice the intrasulcal hyperintensity, which is probably the IV sign, which is famous, which is well known. If you notice the collaterals in the suprasellar cistern, this was a classic moya-moya phenotype. And when you look at the vessels, the presentation might be any of these. You might have bilateral terminal ICA involvement. You might have classic carotid T occlusion with A1M1 with deep watershed infarcts, or you might have a situation where there is both anterior circulation, or they hear the MCA bifurcation, MCA origin, as well as the carotid termination, as well as the PCA involvement in a same patient. So you might have any of these moya-moya phenotypes, which is important in these cases. Typically, a catheter angiogram is needed to assess how the collateral circulation is. This was an 11-year-old girl with TIAs. Notice the left MCA is attenuated compared to the right. The angiogram sort of confirms that the A1 segment of the right is also involved. The left ICA as well as the M1 and A1 are severely involved, multiple collaterals proliferating, and this is classic moya-moya, which you would expect. However, when deciding for surgeries or which patients would go to for surgeries, at our institute, and this is an institutional practice, we tend to use CVR and not ASL. And the reason is that when you use CVR, you are looking at the functional aspect. So here we do breath hold with carbon dioxide. Noma is one of our neurologists who drives the program. Here is an example of a moya-moya where there was a steel on the right side. So this is pre-surgery. And when you do carbon dioxide breath hold techniques for CVR, notice that there is a steal of the blood from the right hemisphere because it was compromised. The left hemisphere seems to be okay. This was following the procedure, the EDAS, 4 months and 6 months. Notice the improvement in the cerebrovascular reserve on the ipsilateral side of the surgery. So this is more of a functional aspect and more sort of definitive in terms of assessing what level of compensation has happened in these patients with CVR. So that's something interesting to remember. We use breath holds because Respiract is difficult in children. Now, the other major category is sickle cell disease. In our patients, about half of them might present with infarcts. 2/3 of them might have some sort of vasculopathy, and that's important to remember. Hemorrhage being more common in older patients. So usually in sickle cell disease, because of the arteriopathy, which involves the sickle cells causing endothelial damage and hypertrophy, you might have presentations like a unilateral large vessel vasculopathy with watershed infarcts. We can see here, you can have a moya-moya-like appearance where the terminal ICA, the proximal M1, A1 being involved, or you might just have silent infarcts and tortuous vessels without significant narrowing. It's important to appreciate these vascular changes early on to prevent a vascular stroke. Some of the atypical presentations you might see in sickle cell was one of these cases where you have a cortical juxtacortical abnormality with diffusion, almost like a press. The SWI was slightly atypical in that susceptibility in the south side. However, the vessels were normal on the MR angiogram, and subsequently he was treated with transfusion and hydration as well as a craniotomy for the swollen brain, and all these changes sort of vanished, and it was presumed that this was related to the sickled slow flow within the terminal vessels because of the abnormal RBCs, and this is something which simulates like a thrombotic microangiopathy. So you might have these atypical presentations you might want to keep in mind. In terms of arteriopathies also, we have non-inflammatory syndromic causes. A huge cohort is present with neurofibromatosis, and for residents and fellows, it's important to remember that you need to image the vessels, or at least look at the vessels when you're looking for NF1s. Typical, they might present with bilateral narrowings. As you see in this case, about 5 to 10% have vascular changes like this. You might have similar changes in trisomy. You might be imaging for other reasons, including deafness, but also have to pay attention to the vessels with moya-like appearance in these cases. The other major cohort is facies. Notice that dysmorphic cerebellum, the ipsilateral Meckel's cave, which is prominent, and the vasculopathy typically will be tortuous. You might have embryonic persistent vessels. In this particular case, there's narrowing as well as aneurysm, which you see near the skull base, and it is important to recognize these changes in some of these syndromic cases. Another case of facies, which is much more florid in terms of both ICS being involved, the basilar probably keeping the anterior circulation, but notice there are no infarcts. So any of these syndromic cases, you have to include MR vascular imaging just to make sure that you don't have any of those potential vasculopathies. Other important categories for residents and fellows is to remember that there are a host of genetic causes, and unlike adults where we don't seem to discuss that as much, pediatric groups tend to have this. This is RNF ring finger protein 213 mutation. Notice almost similar to a moya-like appearance. The carotid cavernous segments involved, some watershed infarcts, and that's something which is established. If you're looking for vasculitis, again, your definitive imaging is catheter angiogram. However, it's important to remember that you want to image at the best resolution. So this is an example of a CNS vasculitis. However, the 1.5T doesn't show that very well in your query whether it's there. The 3T sort of illustrates that. Notice the beading in the terminals, distal vessels. You want to do a catheter angiogram, and the chronic ischemic foci are seen on these MR flare images. Cardiac are a big group of cohort for us, and in this, as more and more complex cardiac heart repairs are done, they might be at risk for strokes. There is a large embolic stroke. Notice the susceptibility on the SWI. There's a clot in the ventricle, abrupt cutoff. The reason why you want to chase them aggressively is that in our data, about a quarter of them tend to recur, and that's the reason why you want to image them aggressively, treat them aggressively to prevent any neurological damage. And that's something which we are seeing more and more with better cardiac surgeries and complex cases being undertaken. Amongst the genetic causes, Col4A mutation is something you might see on the adult side as well, although it's not much discussed. However, in pediatric setups, you might see these multiple chronic hemorrhages as well as infarct, leukoariosis, and porencephalic. Here is a sort of a gamut of presentations of a Col4A mutation. You might typically see porencephalic cyst, prominent vest, perivascular spaces, parenchymal destruction, supra and infratentorial microhemorrhages. You might have tortuous vessels, in this particular case, rarely an aneurysm. You might have congenital abnormalities with a schizencephalic cleft, leukoariosis, and prominent ventricles. Usually affects because of its basement membrane abnormality related to collagen that can cause affect brain, eyes, kidneys, cardiac, skin, muscles, etc. So there is a host of presentation which, but you need to keep in mind some of those varied presentations. This is just to drive home the point for residents that You can have situations where the initial insult is an MCA stroke. This is a fetus at 22 weeks. Notice the MCA being infarcted, follow up at 26 weeks in utero fetal MRs showing a subpial cystic area. 35 weeks in utero MR shows a cleft and subsequently presents with a schizencephalic cleft. So the important thing is to remember that any vascular insult during the period of organogenesis or neuroembryogenesis can result in a congenital malformation, and that might be a imaging phenotype, although the initial insult was a vascular insult. Other common genetic things which you want to remember in the differentials is ACTA2 mutation. If you have seen it once, you'll probably remember this is the rigid shaped vessels, ectasia of the proximal vessels, leukoariosis. You might lack the usual collaterals which you would expect in moya. Again, some of those dysmorphic appearance of the cerebral, the corpus callosum, as well as the brainstem because of these rigid vessels, as well as the crowding of the gyra have been described in ACTA2 mutation. Apart from that, Astik had done a great work on genetic causes of strokes, and there are a host of them. I don't want you to remember all of them, but just to realize from residents' perspective that there are a number of genetic causes which can lead to these strokes. You can see this is a DADA2 mutation. A small ischemic infarct typically involves this brainstem, basal ganglia, and also can have aneurysms or microhemorrhages. Vessels are normal on the MR angiogram here. If you notice that one of our colleagues has recently published here in DADA2 mutations, Anna from Genova. What she has mentioned is enhancing perivascular tissue in the interpeduncular cistern might be a feature of DADA2, so that might be interesting to remember. CADASIL is another important cause. You might see more on the adult side. We don't see that often, but you have those classic changes in the anterior temporal lobe and the subcortical white matter. Now, coming on to stroke mimics, which is a huge cohort for us in patients presenting with presumed strokes through the ER. Migraine is probably the most common cause for patients presenting with stroke-like symptoms. Seizures are another common group. You might have demyelination, Bell's palsy. You might have metabolic causes presenting as or mimicking stroke. So that's the reason why you want to image with MR rather than CT, because CT misses almost about half the cases in these situations. This is a classic example of a patient presenting with a presumed stroke. Notice on the MR you have a negative diffusion, some increased susceptibility within the left hemisphere. The vessel on the left seems to be slightly spastic, and this is a migraine with aura, which you would expect. Metabolic strokes can include MELAS, diffusion abnormalities you can see in the posterior lobes with the lactate. This is classic MELAS. Another example of a perirellandic stroke in the same patient at two different time points in a patient with MELAS. So that's important to remember as when you're thinking about acute pediatric arterial ischemic strokes. Rarer causes also include radiation injuries. Here is an example of a diffuse abnormality within the brainstem. It came with the presentation of a brainstem stroke, vessels normal. However, if you notice, there is some susceptibility at the margins, faint enhancement, and in the presence of a post-operative change in the right temporal lobe, this was presumed to be radiation effects rather than an acute arterial stroke, and that was treated accordingly. So rarely you might see craniopharyngiomas are no longer treated with radiation in most sites, and this is an older case where there was a vasculopathy related to prior radiation with an acute narrowing of the vessels, which you can see presenting as a stroke. Rarely in lymphoproliferative disorders, you might have methotrexate related abnormalities with diffusion changes in the subcortical regions presenting as query stroke, and it's important to recognize this. So you probably want to do some of the MR angiogram, which is normal. Now, dissections are an important cause of arteriopathies and strokes in pediatrics, and when you look at it, intracranial dissections are more common in children, which is unlike adults, and so you would want to focus on that, and typically you would image the extracranial neck vessels also, especially in the posterior circulation. Some of those examples, a 17-year-old male presenting with a hemiparesis and aphasia. Notice the left ICA is attenuated, you don't see any flow. The left MCA, ACAs are also compromised. But however, it's important sometimes if you're suspecting that to do pre-contrast T1 weighted image. This is a vessel wall imaging. Notice that there is an intrinsic T1 hyperincidence in the wall, and subsequently, if you look at it carefully, it's an intramural hematoma, which is the holy grail for dissections. So you're conclusively able to show that there is a hematoma within the wall of the vessel, which would explain the stroke. And in this particular case, an angiogram was done. Notice the double lumen there, the lenticular striates are preserved, and this was an arterial dissection. Another example of a dissection, the proximal vessel being collapsed, the left ICA, but in the cavernous segment, there is some intrinsic hyperintensity with an ischemic insult in the basal ganglia, which was presumed to be a arterial dissection in this particular case. If you're looking at the posterior circulation, it is important to look at the extracranial neck vessels. This was a patient with Tourette syndrome who had recurrent habit of snapping his neck, and unfortunately developed a dissected flap at that C3, C4 level. The MR angiogram showed narrowing as well as distal basilar occlusion. Notice multiple infarcts in the brainstem and cerebellum. That's the cath angiogram showing occlusion of the distal basilar. Intervention was performed aggressively, and you notice the clot, and subsequently some sort of circulation was restored. And luckily for him, he didn't go into a locked-in state and ultimately was able to go home. Another example of a 15-year-old girl, acute onset of diplopia. Notice the ischemic infarct in the pons. The basilar seems to be occluded here, distal basilar thrombus. However, it was read as normal on the MR angiogram. However, subsequent catheter angiogram revealed irregularity and a clot in the V4, almost distal V3, V4 junction. Notice that if you go back to the MR angiogram, there is a irregularity in the extracranial or the side where it enters the dura. And so one of the things for residents and fellows to remember is that when you're looking at these vessels, it might be prudent to cover the vertebrals from C3 onwards if you're looking for any sort of dissections, etc. And that applies to most of these cases, because if you have seen bow hunters, and this is basically a dynamic compression of the vertebrals as you rotate your head. This happens in some of those patients who have excessive narrowing, and in this particular case, bilateral narrowing of the vertebrals. You can see in a segment, in a setting of craniovertebral junction abnormality, you have a pseudoaneurysm and a stenosis, and this patient had bilateral dissections in the vertebrals. That's the C1, C2 junction with infarcts in the brainstem. So Bow-Hunter's phenomena is something you want to keep in mind in posterior circulation strokes in pediatrics, and look for craniovertebral junction abnormalities as well as a dynamic angiogram to prove that there is a hemodynamic compromise. Mineralizing microangiopathies are uncommon causes. You might see it. However, sometimes it might be prudent to do a CT to show that calcification in the lenticular striate. Typical examples would be the basal ganglia within a young child who had a history of fall. Sometimes they are misdiagnosed with fractures, etc., but that's important to keep in mind. For residents and fellows, infection, or most of us know, is an important cause of strokes, but in cases where, for example, this is a case with the bacterial subdural empyema over the convexity, was operated, evacuated, sent home, everybody was happy, comes in with a stroke 3 weeks later. And if you go back to the imaging, notice that there is some tissue around the basal portions of the brain which caused the narrowing in the first place. So for residents and fellow, it's important to remember that even in the setting of an abscess in the convexity or any other cause of meningitis, it is important to look at the vessels in a pediatric site to rule out any impending stroke, and you can prevent that. Last few slides in terms of looking at neonates. We are not talking in detail about neonatal strokes in this talk, but some examples in terms of congenital cardiac, which is a huge cohort for neonatal strokes. Traumatic birth, unfortunately, in this patient, some sort of intervention with forceps and bilateral ICA dissections and multiple injuries. Infections, strep B, meningitis is a huge cohort where there's infection causing ischemic insult to the cortex. And then if you're looking at neonatal strokes, here we were happy to see that there was a MCA infarct, a PCA infarct to be diagnosed, and that was great. But while evaluating the rest of the brain, you notice there is some susceptibility in the pineal region. The MR angiogram, as we said, deranged to a CVR that causes hyper signal in the MCA, but this venogram showed an absent straight sinus. And if you notice, the susceptibility was abnormal there. The CT venogram was performed, which showed a thrombus within that vein of Galen at that site, and that sort of confirms that you can have venous as well as arterial strokes at the same time in some of these patients with coagulopathy. So it's important to remember that something you need to rule out. Now, to just summarize, we went through a host of diverse causes and stroke mimics in this brief overview. Important to recognize the challenges associated. Typically, MR is preferred compared to CT. Code stroke protocol is important, but sometimes it is institutional practice, and there is enough discussion in literature. Vessel wall imaging is something important to remember and aid that not only the lumen, but the wall of the vessel is also important. With that, I would like to thank my entire division at the Hospital for Sick Children, staff, colleagues, and fellows. A wonderful place to work with, and I hope you have a great meeting there. Thank you again. Thank you for your kind attention.